This is the Little Moments Count radio podcast, created in partnership with community radio stations throughout Minnesota. Each episode, you'll hear interviews with early childhood experts on how to support the important brain development that takes place in the first 1,000 days of life, just through little moments every day. Learn more at littlemomentscount.org/podcast.
And good morning, Twin Cities. Welcome to The Narrative here on KRSM Radio, where we amplify the voices, stories, cultures, and conversations that are happening in our neighborhoods. And I am your host, Andrea Pierre, and I am here with our Little Moments Count. This episode of The Narrative is presented in partnership with Little Moments Count. Little Moments Count is a statewide collaborative that is focused on helping parents and caregivers learn about the importance of brain development in the first 3 years of life. Nearly 80% of brain growth happens in the first 1,000 days, and small moments of interaction like talking, playing, reading, and singing help create the pathways that build a child's brain during this early stage of life. For more information, you can visit at littlemomentscount.org. Our guest today is Dr. Nathan Chomilo. I'm sorry. I said it a million times before, and now I'm nervous and saying it differently. So Dr. Nathan Chomilo, and Dr. Nathan Chomilo has worked as, his work centers on the impact of early childhood intervention and healthcare access that have long-term prospects of our children, and how physicians and healthcare systems can address racial and health equity. He is the medical director for the state of Minnesota's Medicaid and MinnesotaCare programs and practices as a general pediatrician with Park Nicollet Health Services and HealthPartners. So how are you today, Dr. Chomilo?
I'm doing good, Andrea.
Chomilo, you got it. Chomilo. I'm going to write it the way that I would say it because I am very stubborn person.
No worries. And the kids often call me Dr. Nate too. So, you know,
Dr. Nate.
That works.
How long have you been in working with the children here?
Well, I've been a pediatrician now for over 10 years.
Wow.
But, you know, working with kids has been something that's been kind of near to my heart pretty much since I, graduated high school. So, we'll talk a little, I'm sure, about, my path to pediatrics, but I always find the kind of energy and light that kids bring to any situation something that really fills my cup and feel honored. I get paid to, play with and hear about all the cool things. What are the cool video games and activities and things that our kids, light up their day. Mm-hmm. And so, be a real honor to just be part of kids' lives and their futures, and an honor to be here talking about how we do that on kind of the personal level in our everyday conversations and actions with our children and families, and then like on a bigger level, the systems that should support our children and families, how we can make them more likely, more better to support our children and families.
Yeah, and your bio, I didn't even read your bio, but it's big. So if you don't know, and I didn't really know about you until this, so I'm really thankful for Little Moments Count bringing you into my sphere. So he is an executive committee member of the American Academy of Pediatrics, section on minority health equity and inclusion, where he has presented nationally on racial health, identity formation in the early childhood, and what parents, pediatricians, and teachers can do to foster a healthy racial identity. He also serves on the board of Reach Out and Read nationally, and in Minnesota, he's an adjunct assistant professor of pediatrics at the University of Minnesota Medical School. He also previously serves as a state of Minnesota COVID-19 vaccine equity director and as a senior advisor of equity to the Minnesota Commissioner of Health. And you've been recognized by the City of Minneapolis Department of Civil Rights as a 2019 History Maker at Home recipient, and Aspen Institute as well as an Aspen Ascend Fellow in 2022. And in 2023, you were also selected for the National Academy of Sciences, Engineering, and Medicine's Committee on Improving the Health and Well-Being of Children and Youth through Healthcare System Transformation, and named to the Lancet Commission on Anti-Racism in Solidarity. And you're also a father and husband. And you got
my most important title.
Yeah.
Right there, yeah.
Oh, I love that. Yeah. How many sons do you have? How many children?
Two boys.
And how long have you been married as well?
You're gonna put me on the spot here. No, we've been married for will be 13 years this year.
Oh, God bless y'all. That's beautiful. Congratulations. I love hearing that. So, being a doctor, being a father, being Black, and dealing with a lot of like the health, racial identity, and health equity things, and being in Minnesota where there's so many disparities, it's a lot on your shoulders. And like, how did you come to know that, hey, I want to be a doctor, I want to do this work? Because you wear so many hats.
Yeah, and I think, a little bit of my, background explains why, I just try to show up wherever I can. And so I was born in Minneapolis. My parents were born in Cameroon in West Africa, but they met in Minnesota. And my dad was in pharmacy school at the time. My mom is a nurse. And even though my mom grew up in Cameroon and went to high school in Nigeria, she's Norwegian American. Right? And so I grew up kind of as a biracial Black man in predominantly white spaces. I grew up in the Cameroonian and West African immigrant community, as well as the Black community here in the Twin Cities. And so those things all kind of informed, my path, and, seeing my parents, the way they showed up in different community spaces. Folks would often come up to them asking them questions about their medications or, this rash or, twisting my ankle or whatnot. And, what they really were asking is, how do I kind of navigate the healthcare system? From a young age, seeing that folks trusted my parents and to get that type of help, it gave me, trust in them. It gave me a desire to want to, help people and be that type of person in my community as well. And so as I went through high school, I was really interested in the sciences, really interested in learning about the body. And, I knew that my dad actually had thought about going to medical school. I knew that my grandma on my mom's side had wanted to go to medical school, but was told at the time that, that's not what women did. Right. And so kind of both my interests and my exposure to kind of the health and healing professions, and a desire to want to be one of the, the first doctor in my family, led me to go to medical school. And when I went to medical school, I was always thinking about pediatrics. As I said before, even before landing in medical school, I was a volunteer camp counselor. I coached soccer. I played soccer throughout my life, and found my ways to the sideline to coach kids as well. And so, thinking, I'm going to become a pediatrician. And as I, went through medical school, learned more and more about what were the social determinants of health, or what called the social determinants of health. These are the things like our housing, our nutrition, our transportation, our exposure to like clean air and water, that all impact our health in ways that don't really show up in the clinic. As far as like, as a doctor, I can't prescribe, clean water. I can't prescribe housing. And so thinking about what are the things I can do as a physician to address, social drivers of health is, started to become more and more of kind of how I was hoping to, practice pediatrics. And so, that led me to learn about a program called Reach Out and Read, which you mentioned there, that I continue to this day. And I find it one of the real turning points in my life. I went to this kind of lunch talk my first or second week of internship after graduating medical school, and I heard about Reach Out and Read, which is an intervention where doctors provide books to kids when they come in for their checkups. Just bringing your kid in for their shots and seeing how they're growing and everything. And they provide a book that's developmentally appropriate. They talk about how do you read with a 6-month-old versus reading with a 1-year-old versus reading with a 3-year-old, and then give them encouragement and modeling and, how to do that. And that kind of simple, 5-minute or so intervention, a few dollars for the book, that doesn't get passed on to the family, that the practice pays for, has been shown to, help improve how often children and parents list reading as like their most favorite activity. It's been shown to improve the trust that children and families have in their pediatrician. And then, when you think about the social drivers of health. It's been shown to improve the number of words, the vocabulary of 18-month-olds. It's been shown to, improve how ready kids are to show up to school, knowing some of those fundamental pieces of language. And really that resonated with me on a number of levels, right?
Yeah.
Reading to me was always kind of one of the things I identified as my success academically. I remember getting competitions with my younger brother for those like Pizza Hut bucket competitions, where you read as much as you can, you get a free personal pan pizza, and we were always going back and forth who's going to get the most pizzas, growing up. And so to me, it spoke to me on such a number of levels of like identified with my own personal story of success. And I learned more about the inequities around reading, right? Like not everyone has access to books. Not everyone's parents, know or have been told that, you really are your child's first teacher, and you can start at a really young age. You don't have to wait until they get to school to, start doing some of these activities. And so really thinking about how as a, pediatrician, I could be one to incorporate into my practice, and then thinking about, well, how do I get this word out to the community? Because I made it all the way through medical school without hearing about this intervention.
Really?
Mm-hmm.
Interesting.
And so, it was that to me also was like, wait, what this has been going around, existed for like 15, 20 years. How come I didn't see it in my own life growing up? My doctor never talked to me about reading growing up.
Yeah.
How come I didn't learn about it in medical school? How come it's not like the standard of care? And so, offering my, time to kind of help the Reach Out and Read organization, and in the process of that learned more. And, that has led to a lot of the different advocacy. And, we can talk a little bit more about my journey, because I could take up a good chunk of time here. But yeah, I think, that kind of, realization really allowed me to kind of then keep growing and keep asking questions.
So just for me to repeat back to you for my own understanding, so you went to school to become a pediatrician, and they never really explained to you, you didn't really hear like about the reading aspect of like how much it can help with the brain science of the, wow.
Yes, correct. And in fact, that brain science piece, that stat you threw at the top of the hour, 80% of the brain is developed in the first 30 years of life. I learned that on my own after I started learning about the Reach Out and Read intervention, and that led me to more and more, understanding about early childhood. And those are things that, we don't hear in like just your core curriculum of medical school. Pediatricians do get some of that in their training, but not all doctors, even know that basic.
So in your practice, and I don't know if you're still practicing, are you still actively seeing families then? Yes.
Yep, in Brooklyn Center.
So then how do you explain that brain science to your families? Like can you pretend like our listeners are the families? Can you simply explain the brain science of that 80% of a child's brain architecture develops in the first 3 years of life? So how would you say that if our listeners were your patients right now?
Yeah, and for me, I think the thing that has driven it home, sometimes I learn best visually, right? And so one of the things that I saw in some of the first talks was this kind of slide of what does the brain connections look like in kind of a young child, in a child who's like 15 months and a child who's 3 years, right? And, if you can kind of imagine a plate that has maybe just a couple kind of spaghetti noodles on it, and that's kind of like what the brain looks like. There's not a lot of connections initially,
like the synapse.
The synapses, exactly. The neurons, the nerves there that are making those connections, and that builds the kind of core of so much of what we do and how we think and move. And then as you get to 15 months, you see more noodles kind of show up on that plate, right? And then by the time, it's 3, like the plate is full of noodles, and that's all those like connections together, right? And so, when I talk about Reach Out and Read, I usually don't, go into the brain science as much as, here is a book, and we know that, if you're sharing a book with your child, even up to 5 minutes a day, that increases the chance that when they go to kindergarten, they're more likely to succeed and be ready to succeed. And then here's the way is, for kind of a 6-month-old, it's just kind of showing them the book, getting them used to what a book does, turning a page. And sitting in your lap. And as you get older, using the book as a prompt to say, here's a ball. Can you say ball? And then as they get a little bit older, saying, oh, do you remember the last time, here's a dog. Do you remember when we saw that dog in the park? And, using the book as more of a prompt for conversations and reflections. And then as they start to get in their words, here's the book. You tell me what you see, right? And really it's kind of how do you have a relationship that kind of invites children to be curious, look at the world around them, use their language in a number of different ways, that increases those connections. That puts more noodles on that plate, if you will, to help the brain grow, and then again sets you up for success and that kind of lifelong journey of learning.
So let's talk about that, the long-term education and health benefits from getting those first 1,000 days right. Like, what have you seen in your practice?
Yeah, I mean, so what we know is if you do show up to school already, then you're less likely to fall behind, right? And one of the kind of transitions and turning points is we know in those first few years, you're kind of learning to read. And then if you fall behind, and it's really troublesome once you get to like fourth grade, because that's when you're reading to learn, right? And so that's when they see, you look at fourth grade kind of reading scores, it does have a lot of prediction on your ability to graduate high school. The chances that you'll end up involved in the legal system or needing some type of social assistance going forward, will increase if you are struggling to read, by that fourth grade level. And so this gives us a chance to kind of give kids the foundation. I always talk about how do we help them reach their full potential, right? And because that's what so much of health equity is. We know there's going to be different outcomes. Folks have different skills, different abilities, but what we want is to make sure everyone has at least a chance to reach their full potential.
I like that, chance.
Yep, and right now we don't have that, right? We very much know that there's certain folks, families, communities that are more resourced and that are given more chances to reach their full potential versus others.
So I'm really glad you brought that up because, as a medical director for Minnesota Medicaid and MinnesotaCare programs, and Minnesota's just having so many different, like in the news, we have the biggest health disparities. What are the key challenges that you've encountered ensuring healthcare access and equity for all the children in our state?
Yeah, I've looked at it through a number of different lenses. One is just how do you get access and eligible for things like health insurance. In our country, since we don't have healthcare for everyone, the way most folks access healthcare in the first place is through insurance. And so we know that the process to get that usually is tied to your job, and if you don't have a job that offers that, or the job you have, you don't make enough money to make that really feasible to be paying for it, you could potentially qualify for our state insurance. But even the process of applying and staying applied to that can be daunting and challenging and confusing and complex.
But it's such good insurance.
So
when you have it,
once you get it,
it is good insurance once you have it. I wish I had it.
Once you get it, yeah, there are a lot of benefits to it, right? And so it's some of our work, particularly during the COVID pandemic, the federal government paused that reapplication process. So they didn't want to kick anyone off of their healthcare insurance in the middle of a crisis. Yeah. But then they put the rules back in place last year, and so we've been over the last year having to help people be aware that they have to go through the process and trying to streamline our systems. And so I think just access to healthcare insurance is one. We know that as we talked about at the top, so the social determinants of health, right? That even if you have health care, that alone, there's some studies that say it only accounts for about 20% of what we would actually define as someone's health. And so the rest of it is somewhat in your family. And a lot of it, though, is your environment, right? And so, stable and safe housing, nutrition that is good and optimal from the very beginning. Even your mom's nutrition when she's pregnant for you can impact your health, right? The air we breathe, the water we drink. And we know that because our neighborhoods have largely been redlined along the lines of race, that and alongside
environmentally safe.
Alongside that, the places where you see factories, where you see lots of traffic, are also been predominantly put in our neighborhoods, that we have different exposures, right? And so some of these disparities and gaps and equities we see stem from things that aren't really actually even related to what's happening with you and your doctor. It's so many other things. And so I think that's why these inequities, continue to persist. They've been developed over a course of decades and generations. It's going to take us some time. I think there's a lot of, positive steps that we've seen, but, we have to be real that it's going to take a continued and sustained, investment and efforts to undo the harm that's been done and make our communities whole.
Mm-hmm. I almost feel like when you say I almost feel like a lot of people's introduction to the healthcare system might be the emergency room, like when something's going really, really wrong. And then you get that bill. And I feel like a lot of communities of color, or just people in general, I'm not going to say just communities of color. I think people are afraid to go to the ER sometimes just because of the bill, are afraid to call for emergency services because of the bill. And I don't know how good of a job we're doing as a society in making sure that people feel safe enough, or comfortable enough to call for the help that they need, or even going to get the checkups that they need. And how is the state? I don't know if the state's necessarily helping that,
Yeah, the state is, doing a number of things to try to improve, access. And but I think, what you're, touching on is, a lot of folks have kind of reflected that we don't really have a healthcare system. We have a sick care system, right? Like a lot of the things that the healthcare system pays for is actually just, procedures and showing up when you're sick. It doesn't really pay for the preventative services that folks need and could benefit from, other things that we know promote health and well-being. And so there is some efforts at the state to kind of try to change, how we pay for healthcare, how we pay for outcomes, so that it is more grounded in, preventative care, healthcare. There's some efforts to kind of use grant funds, so funds that aren't through kind of like the Medicaid program, but actually from the state's budget, to work with communities to kind of define some of the healthcare needs and priorities. One in particular is integrated care for high-risk pregnancies grant that we have several different grantees. One is the Healthy Black Pregnancies Coalition that really does try to work to understand, what is a more collaborative care model look like that involves doulas and community health workers and the providers, involves things like group sessions and community events. And so thinking about, how can we really better restructure the dollars that we have to be more guided and dictated by the communities. And in my lens, when I say community, I'm really focusing on communities that have been impacted by structural racism, right? And so in Minnesota, we know that it's our Black and predominantly U.S.-born Black Minnesotans and American Indian communities in particular.
Yeah. And that's a big population of our community center right here in Phillips. If you're just tuning in, this is The Narrative here on KRSM. I am speaking with Dr. Nathan Chomilo, who is the medical director for the state of Minnesota's Medicaid and MinnesotaCare programs. And we just need to take a really quick station break, but we'll be right back with more from him in 1 second. And welcome back to The Narrative here on KRSM Radio, where we amplify the voices, stories, cultures, and conversations that are happening in our neighborhoods. We focus on communities that have been historically ignored, misrepresented, and erased by traditional media. I'm your host, Andrea Pierre, sitting here. We're doing our Little Moments Count episode with Dr. Nathan Chomilo, who is the medical director for the state of Minnesota's Medicaid and MinnesotaCare programs. And I'm kind of happy you kind of brought up the Black and brown communities, are the Native American or indigenous communities here and Black communities here in Minnesota, and just like the long-term prospects and health outcomes of the children here. And I'm really just curious about, I know with COVID, there was a lot of money that got flooded in, and it was able to help a lot of people. And now, since all that money has been ending, it feels like there's an even bigger crisis emerging in my eyes. And I know I'm not an expert, but am I tripping?
I don't think you're tripping. And I think, that's been, some of the moment of hope and then, frustration that I was seeing is that when the, COVID-19 pandemic hit and everyone was at risk, right? All of a sudden that checkbook was pretty loose, right?
Yeah.
All of a sudden we could just start printing money for a number of things. And then we saw the benefits, right? The child tax credit automatically going into folks' bank accounts, cut, poverty around the country, almost in half. Child poverty in particular, right? And so, and then a lot of the ways that we help folks access benefits that they're eligible for, like food benefits, housing security, and not being evicted. And then, as we talked about earlier, staying on your healthcare insurance and not having to, fill out a form to justify that you still, or your child still needs that health insurance, right? And so all these kind of policies and the funding, was really liberalized in an attempt to, because everyone felt that threat, right? And I think now we're seeing us go back to kind of, or try to, a lot of folks want to go back to kind of how things were before. But a lot of us realize that, like, we can do different. We can be better. I always reflect that in the richest country in the history of the world. How do we not have a basic guaranteed access to healthcare? How do we not have housing? How do we not have just a basic guaranteed income for folks? And thinking about what that would unlock as far as our potential within our communities and within our country at whole. I think we would all benefit from those type of policies. And so I think, there's going to be this time of transition because a lot of that, funding that you were touching on there was from the federal government that has gone away. Our state has, I think, made a lot of wise choices in the last year and stood up and is standing up programs that will, make a big difference. And so we talked about the federal child tax credit. The state passed one that is projected to help decrease child poverty by at least a third. And so, making sure folks get the access and support to fill out their taxes so they get eligible for that tax credit for them and their families. Paid family medical leave was passed last session. And so that's going to provide a universal benefit for everyone, no matter your job. As long as you meet a certain number of hours that you work, you'll have access to that, and that's huge. That's one of the things where efforts like Little Moments Count are essential to provide education and awareness. But if you're super stressed because you're working 3 jobs, like, how are you going to have? Sometimes I've heard from parents like, I don't know if I really have time or energy to even spend 5 minutes reading with my child, or they're just so all over the place, and I just need my time and my rest. And so if we really want to, give parents an equitable opportunity to be the caregiver that they want to be for their children, we have to think about how do we support parents too. And so I think there are, again, we saw a lot of great funding, great policy changes to support families and children in response to the COVID-19, acute pandemic. And I think my hope is over time, we'll also be able to kind of learn and look at what were the ones that really worked and make the case to, either if they weren't continued, restart them or, tweak or add on to them going forward.
Yeah, because you definitely had like an up close look, because at that time you were working on the Equity, you were the senior advisor on equity during that time too, to the Minnesota Commissioner of Health. I think that's why a lot of people are like, well, we were doing better during COVID. And I'm like, well, because he was getting a lot of extra money. And things have changed and we can't go back the way that we used to be. It's not, the world's different. Our minds are different. We just can't. I want to make sure I think about this. Okay, so my mind's like racing because there's so many different questions about equity in this state. And I am thinking about, when it comes to like the work that you've done on just race and racism in the context of healthcare and development, like how do you bring that up? So what are some common concerns or questions parents bring up regarding race and racism in the context of their child's health and development during like your consultations and when you talk to them? Because I bet you do have like a unique perspective as well, being like biracial yourself. So
and I would say the beginning of my practice, so I think we talked about at the beginning, I'll be in my practice for 10 years that come this August. And so at the beginning, it wasn't really explicitly brought up, but the ways I would see it brought up is, which parents and families were telling me that their kids were being threatened with suspension or expulsion for bad behavior, or being referred to me to get an ADHD evaluation because they were hard to control, right? And really then as you kind of talk about what's going on, and are they only seeing this at school versus what are they seeing at home? And, are they concerned about it, or is it just what the, teachers or schools concerned about? I think that's been kind of one of the main ways. I think the other way is, thinking about like what are good books or movies or things, to read, to help my child kind of navigate, like they saw something on the news, right? And so, Trayvon Martin, here for me, Philando Castile was a big kind of turning point in some of my work, and where I really started to reflect more on not just social drivers of health, right? But in the wake of Philando Castile's murder, thought much more myself about how is healthcare also contributing to the death and suffering of our community. And it's not just a split-second decision of, a cop shooting a black man or woman, but it is a number of decisions by healthcare professionals over the course of folks' life that take us away from our families early, take us out of our community early. And so that type of interrogation led me to think about, like, what is my role as a pediatrician, right? As, someone who is trying to help parents. I would say I'm the kind of child health expert. You're the expert in your child. And together, we hopefully, give our children the best shot of a healthy, happy life, right? And in that perspective, thinking about child development, how do we help address racism at its core? I'm sure folks have seen, those kind of viral memes or, videos of like toddlers from different backgrounds, like hugging each other, and, kind of helps us reflect on like we weren't
those feel good moments.
Yeah. That like we weren't born with this kind of, hate or mistrust or, but we are, socialized to it. And how does that happen? And so that led me to a book that I think everyone who works with kids, should read. Why Are All the Black Kids Sitting Together in the Cafeteria by Dr. Beverly Tatum, in it, which she talks a lot about, what is called racial identity development, and thinking about, how do we understand ourselves and others along the lines of race, and, who contributes to that. They're called who contributes to what's called racial socialization. A lot of it's obviously our parents and our family, but it's also the books we read and the movies we see and how, different groups are portrayed. In that, it's what we hear from our teachers and from our classmates. It's what we hear when we go to, our church or place of worship. All these different spaces are kind of socializing us to, again, think about ourselves and who we identify with and don't identify with. And then that then has impacts on your mental health and your well-being and thinking about, others and how you want to treat others. And so as a pediatrician, I was really surprised to learn, again, another thing I didn't learn in medical school, another thing I didn't learn in my pediatrics training was, when does this process start? And racial identity formation starts very early. Some studies say as early as, 3 to 6 months, children can start to identify differences based on the faces of their caregivers. And then when does that start to be internalized, right, by the child? As early as 3 years of age, they're seeing children start to internalize messages, good or bad, about race, and they are actually using race to kind of figure out their own social play networks in preschool, right? And so, understanding that gave me an opportunity to say, hey, as a pediatrician, I can talk to parents about this. I can say at our checkups, your child's 3 or 4 years old now. They're going to start asking you questions about, why is my hair so curly, or, why is their skin darker than mine, and kind of talk about, there are ways that we can advance our racial identity in a healthy way, intentionally, but there's also ways we unintentionally do it that we need to be aware of, right? And so it is those books and media. It's, when we drive through a certain neighborhood, do we lock the doors and kind of like act a little more like anxious, right? Children pick up on all those verbal and nonverbal signs, right? And so well-meaning parents can be socializing their kids to have kind of racist or biased ideas without knowing about it. And so giving them the language, giving them the understanding and the timing. I usually point to resources like Embrace Race, embracerace.org, Raising Race-Conscious Children. Has great places to go and learn more, where I, as a father of 2 biracial boys, have learned a lot about how I'm going to have these conversations, or I'm having these conversations, and from there, that is evolved. And my practice is now one where those are conversations I'm having with everyone. So it's not, a lot of the initial literature about racial identity formation was, how do Black parents socialize their kids to navigate a racist world, right? And how do they prepare?
And that's putting the onus only on the Black kids.
Exactly.
And it needs to be everyone's
and it
job.
really needs to be everyone. And when I talk in, bigger spaces to kind of teachers and parents and others, I, reflect on, I don't think any white parent wants their child to become like a mass shooter who, propagates, hate and bigotry, right? And so they too want their children to be healthy and happy. And so giving them the tools will help them reach their kids' goals. And I think will help all of us, have a healthier, happier society.
Yes. And if you're just tuning in, listener, I am speaking with Dr. Nathan Chomilo, who is the medical director for the state of Minnesota's Medicaid and MinnesotaCare programs. This is our Little Moments Count segment. And, you've been really involved with the American Academy of Pediatrics and working on racial and health equity as well again. What role do pediatricians really play in addressing that systemic racism within the healthcare system? Because every time you say you didn't learn that in school, I feel so incredibly disappointed. So what steps is like the AAP taking to, even just address that change, or like what's going on? Yes.
And so you can maybe see why I wear so many hats is because I just see so many opportunities, so many gaps in our systems, and a need for someone to talk about it and then hopefully think about ways to move forward. And so I love the AAP because they are one of the few, to me, physician organizations that very early on said, hey, we're here about the patients and not just about protecting our bottom line, right? Okay. And that's been an issue with me with physician organizations throughout my career. Is a lot of the physician organizations are really trade organizations that are just trying to make sure that they continue to protect their part of the market, that they get paid, and even if that means less people have access to care, less people who look like us have access to care in particular, right? But pediatricians, since they advocate for kids don't vote. They've been about the conditions and changes that help all kids flourish. Not often, or I should say, not historically. Always all kids, like many institutions in our country, but they, I think, have been most at that leading curve as far as really starting to understand what it means to be more inclusive, to really value diversity. And so, we talked a little bit just now about what pediatricians can do, and that as far as talking about racial identity formation, right, and how we can potentially help mitigate the formation of racial bias and racism in our children, in our families from the start. And so I've given lectures locally, nationally about that to help pediatricians understand. I've written up scripts of like what I literally say to parents in the exam room, so other pediatricians can work off of that and then use what they feel is right as far as how to have those conversations and where to go from there. But to your earlier reflection that you've heard me kind of say over and over that I didn't learn this, I didn't learn that, education is huge. And so that is one of the areas where, my work with the Minority Health Equity and Inclusion section in AAP is what we call the American Academy of Pediatrics, with the AAP has been thinking about how do we, have that education be part of the core curriculum, that no one can really, become a pediatrician without understanding, those pieces and be able to implement it. How it's important, we talk about, I often talk about how I'm not where I am. I should say I 5 years ago, I wasn't where I am now when it comes to my own journey and reflecting on race and structural racism and even broader concepts like equity and solidarity. And I hope to not be the same place in 5 years. And so how do we help also build that type of kind of growth mindset when it comes to these concepts? You have to sometimes unlearn a lot. I, as a, again, biracial Black man who grew up in predominantly white spaces, had to unlearn a lot of, what I had been taught directly or indirectly about race. And so I think that's something, physicians are humans. I think we sometimes forget that because of the place that they've held in society for so long, but they are fully, able to make mistakes and have biases. And so how do we help them kind of learn and unlearn what they need to know? And the
especially when institutions are cutting DEI programs. Like it's kind of scary actually, because I feel like we're going so much more backward.
Yeah. And that's, we've seen what I, call the backlash, right, to a lot of the movement and progress that folks said they wanted to make after George Floyd's murder. And there's been the kind of backlash to maintain the status quo to white supremacy is going to white supremacy. And so how do we really have institutions that are willing to kind of stand up and kind of stay firm through that backlash? I think the AAP has been not perfect, but has been one of the ones that has done a lot to kind of push back against some of that backlash. For one example, they released a policy on denouncing kind of race-based medicine, right? Mm-hmm. And so this is a concept that, like if you show up to the doctor, we take a sample of your blood to see how your organs are doing. People might not know that there's actually like different correction factors based off of race. And so I often use myself as an example again, right? My white mom and my black dad go and you test their blood for their kidney function. Mm-hmm. Even if their kidneys were actually operating the exact same, you would get a different number because someone would put in that my dad is black and my mom is white, right? Same thing for things like lung function and other scores around certain health conditions. And that's all based off of racist ideas that have started back in like the 1800s, really to justify the institution of slavery and in land theft, saying that, these people are different than us. Look at their bodies are different. They tolerate pain differently, right? And so there was even a condition that one physician who prided himself in, the term at the time was diseases of the Negro, Dr. Samuel Cartwright, talked about that folks trying to escape slavery were actually, mentally ill.
Oh, wow.
Right. And so like, it's like, oh, we need to help these people because they're mentally ill. And you actually see that throughout history. There in the 70s, 60s, and 70s, there was a term, the protest psychosis, right? And that there was black men and women being institutionalized because how could they be so angry? Like, and given, antipsychotics. And you can see even some ads for that show, here, use this antipsychotic medication to kind of calm this, protesting African-American, right? And so these are ideas that have kind of persisted influenced how medicine is practiced, how it's taught. And so really working to identify that and then take that out of how we actually practice medicine. And so the AAP has, really done, I think, the most of a lot of the physician organizations to say, hey, as part of our place in medicine, we're going to start taking that away. We're not going to have that be part of our guidelines for clinical care anymore. We're going to go back and look through our previous guidelines and try to, again, identify where it is, take it out. When we have folks come and talk at our conferences, we put things in our journal, which is one of the most impactful journals in pediatrics in the world. We're going to make sure that we aren't, furthering this idea of kind of race-based medicine, right? Mm-hmm. And so that is, again, another big step towards kind of just, how we practice medicine in addition to, how do we teach and educate, the future learners.
And I kind of asked you this off air because, like, don't people want to see color though in medicine? Like, don't you want to like be like, hey, if you're black and you're, you have bruises, don't you want to be like, hey, you're black, we probably should test you for sickle cell, or you're black and you're menopausal, and you're having a lot of hot flashes, maybe we should check you for cardiovascular disease. Like, don't we want some of those things though too? Like, and like I told you offline, like I'm playing devil's advocate here,
yeah.
But don't you want some of those things?
Yeah. And I think it is a little tricky because we don't want to be colorblind, right? So, denouncing kind of race doesn't mean that we are looking to be colorblind. Mm-hmm. What it is that, your race doesn't have a genetic component to it, mm-hmm. right? Like there isn't just because you're black that, you should be more susceptible. What makes us at higher risk in certain things is racism. Right? It's how we have structured our society, who has access to certain resources, like we talked earlier, who's breathing what air and drinking what water. That is what has really led to differences in so many of the health outcomes. Certainly, there are families. We know that there are families that experience different rates of cancer, different rates of diabetes, and things like that. But if I just didn't ask you questions about your family because I assumed because of your race that I'm going to miss that information, right?
Right.
Sickle cell is one that's often brought up, but we know that there's folks who are kind of white and live in the Mediterranean that get sickle cell. Mm-hmm. India is one of the places that has a lot of sickle cell individuals, and you wouldn't necessarily think about that. but it's again because of the place in the world and your family history that we want it, and we don't want to like turn off our mind just because we assume something about your race, which by the way, most of the time prior to like maybe the last 5-10 years was charted based off of like the person that checks you in's assumptions. Because I can't think about any time in my own personal history that someone asked me what race I was, right? But I'm sure if I look at my chart, I'm black, right? But like, again, that's not
that part.
Then no one's going to, or I've been guessed to be Indian and Sumatran, so who knows? But, but I think that, is another factor of it, is that there's a lot of assumptions that are built in that then we are missing. So race can be a proxy, but we need to ask more questions. And so, to the broader thing is, we want to look at race at cross populations, right? And so I do say that when someone's in front of you, at the bedside in the clinic, we really shouldn't be using race to dictate those conversations. We use more questions. When we're looking at population health, looking at across communities, then we use race as a way to look at the impact of racism. Right? Because we know that because of how our society has been structured along the lines of race, that there are going to be increased risk factors for certain things because of racism, but not because of a biology or a deficit in our genes. These are deficits in how society has treated us and our families over generations.
Oh, word. Thank you very much, Dr. Nathan Chomilo. We're going to take our last little station break here, but I am talking to Dr. Nathan Chomilo, who is the medical director for the state of Minnesota's Medicaid and MinnesotaCare programs. This is the Little Moments Count segment here on The Narrative, and we'll be right back. Welcome back to The Narrative here on KSM, where we amplify the voices, stories, cultures, and conversations that are happening in our neighborhood. I'm doing our Little Moments Count segment with Dr. Nathan Chomilo, and I am so happy to have him here. He's the medical director of the state of Minnesota's Medicaid and MinnesotaCare programs, and we're almost running out of time, but I did want to ask you, how can pediatricians collaborate with other healthcare professionals and community organizations to address the intersection of race, racism, and children's health, and even intersectionality? Because we need some intersectionality going on in order to survive too.
Word, yeah. I mean, there's so many things that are driving the inequities and gaps and disparities that we see. And so one of the things that, in addition to kind of my own journey of addressing structural racism, in 2016, after the presidential election, then there was a lot of physicians that came together and said, we're worried about our safety net. A lot of folks were talking about how, because of how the presidential election went, the Affordable Care Act was going to go away, right? And so we wanted to make sure we could do what we could to, protect our safety net here in Minnesota, and we started an organization called Minnesota Doctors for Health Equity. Right? And so that has really been focused, and again, it speaks a little bit to what we talked about earlier, how physician organizations have historically been interested in just their own bottom line first, and then if it makes sense to align with patient interests, that's also helpful. And we want to be patients first, right? And with that, we wanted to also figure out ways that physicians could show up individually, and so thinking about how, and so this goes for pediatricians, but it goes for I think all physicians, even pediatricians who are amongst the lowest paid, we still make well above the median. And so thinking about what you do with your own money, right? And I think a lot of times we want to look out there and say, oh, you got to do this, you got to do that. Our organization should be doing this. But literally, what is your own 401k doing? Mm-hmm. Is it going towards organizations that are, creating weapons of mass destruction, tobacco, thinking about there's socially responsible investing. There's other ways to kind of make sure that your money isn't in a misalignment with your own values and harming our communities. And then thinking about your space within the clinic, right? And how you can actually think about the communities that your clinic serves. Yeah. Who's already doing work there. We don't have to, I think physicians sometimes, we both get socialized, and because we're kind of leaders in our teams and our healthcare, we think, oh, we got to figure it out and we got to solve the problem.
It's not only y'all.
And it's not only y'all, and we don't have all the answers, and we didn't even get to talk about how in medical school, 80% of folks in medical school come from the top 20% income-wise, right? And so, the lived experience of physicians as a group just isn't there to really understand the challenges. I've had family members who've had to go through the application process and have gotten their healthcare through our public and state health insurance programs, and not too many of my colleagues, themselves can say that. And so thinking about who's doing the work and how can you, again, not come in there and lead it, but support it. How can you help, connect those folks to other folks, whether it be funders, whether it be, decision makers like state legislators, folks at your own healthcare system who have access to resources to make sure that they are getting in front of the people that can help either spread their message, spread their work, or help support it in other ways. And just with the virtue of having those two letters, MD, after your name, you have access to a lot of different places and spaces a lot easier, right? Than so many of our community organizers are folks who are doing the work day in, day out with our community members. And so how can we actually leverage that privilege in a way that, again, doesn't center ourselves? And I think that's a part that a lot of physicians are still learning how to do, but centers the communities that we serve in those organizations. And then similarly, show up in places and spaces like the Capitol, like City Hall, alongside our community members, again, following their lead, and then using our resources to kind of advocate for change and health in all policies, right? And thinking about what is the health impact of some of our education policies, what is the health impact of our transportation or criminal justice, our housing policies. And so providing that lens, because I think that sometimes then makes that, you're touching on that intersectionality, be more real when there is, a health professional that's standing alongside saying, this is not only important for, the stated goals of, this education law, but this is the health impact. And these are the ways that it really helps our communities across the board.
Yeah. I'm kind of glad that you brought that up because, something that I noticed, and it goes across like racial lines, is just that the divide between not only like racial biases and everything like that, but just class. And I feel like there's a huge class issue, not only like amongst like communities of color, but just period, like, the wealth divide, the wealth gap. But like, I think that's like a bigger overarching theme. And maybe like we're all fighting over these crumbs, but the bigger issue is class, and how it's destroying us and hurting us. And how are you seeing that within your work?
Yeah, I think one of the things you noted in my intro there is my recent appointment to the Lancet's Commission on Anti-Racism and Solidarity. Mm-hmm. And I'd say that's been some of the biggest growth in my work, is thinking about what does solidarity really mean, right? And I think some of what we've done with Minnesota Doctors for Health Equity is try to be more in solidarity with our communities than historically we've been. But that, to me, is that seeing us as our fates all intertwined, right? Mm-hmm. That we don't have to have the exact same vision or dream, but like together we can get and create something that serves us all. And I think that is, where the issues of class and kind of race really have intersected historically, because, racism and classism, Dr. Eva Mex-Kendi's talked about them as being, cousins, right? And how that they really kind of feed off of each other, and are able to keep the folks at the top keeping at the top and keeping resources for themselves, and giving us this false sense of scarcity. Because again, we live in the richest country in the history of the world. We saw what we were able to do when pandemic, threatened everyone. And then we saw the decisions that have been made, since then. And so I think this idea of scarcity is a false idea of scarcity, that there is enough for us to all, whether it's not in the systems we currently have or, the world we're moving towards. I think really have enough to find our way there together. And I think, finding ways to, again, challenge that narrative, because it is a lot easier than for them to divide us if they say, oh, this is all you have and you guys got to figure it out, versus saying, no, why is that all we have? And what are the trade-offs? What are we actually, saying that we're willing to deal with to avoid having these harder conversations as far as, who gets taxed, how our monies are allocated, who is the decision makers at the table. I think one of the models of care, bringing it back to healthcare, that I've really tried to examine how could we see more of our community health centers, because they're governed by the actual folks in the community, right? What would it look like if, the large health systems and the large health plans, insurance plans in the world were governed by the people they were serving instead of being governed by capitalism and the bottom line, right? And so thinking about what are the changes and shifts so that these resources can be more equitably distributed, what are the measures of accountability we can build in, which is some of what my work at the state is really trying to do, is build in more accountability to our communities with the state resources, and again, our communities being our Black and Brown communities in particular. So I think there's a lot to work there. I'm hopeful that we continue to work more together in truer solidarity, and that if we are, then I think we'll pass on a world to our kids that is a lot brighter, and they'll have different challenges. They'll have challenges, but hopefully they're different challenges, not the same ones that we're talking about right now.
Right. Hopefully it's just like, what's for dinner?
Yeah.
How can folks get a hold of you? We have to wrap up the show, unfortunately. There's so much more to learn from you, so I'm hoping that I could have an opportunity again sometime to learn more. But how can folks, if you're open to it, learn more about you or just follow your work if they're interested?
Yeah, absolutely. And would love to be back on and continue the conversation. So I am on social media, was on Twitter, but not so much anymore since Elon kind of ruined it. Yeah. So you can find me on Instagram, though. It's my last name, Chomilo, then MD, so at Chomilo MD, and pretty much across any social media platform, if I'm on it, it's at Chomilo MD, as well as LinkedIn, and then certainly I have an email that you can reach out through the state. It's my first name, last name, nathan.chomilo@state.mn.us, particularly if it's questions about our work at Medicaid and MinnesotaCare. Love to hear about ways that we can make it better and kind of be able to lift up folks' voices and experiences in that space too.
Thank you so much again. I want to thank everyone for listening to The Narrative. You can hear a recording of the show at the littlemomentscount.org. /podcast. And if you'd like to learn more about Little Moments Count, you can visit their website at littlemomentscount.org. And for all of our listeners, you can also hear another replay of it on KFAI 90.3 FM on Wednesdays at 1 p.m. And of course, I'm always going to be here at my home on KRSM on Tuesdays and Thursdays at 9 a.m. We are KRSM 98.9 FM Radio for All. We're a social enterprise of Pillsbury United Communities. And if you have a show idea or you think you want to be a guest, you can let me know. My email is andreap@pillsburyunited.org. And I want to thank everyone for listening. Thank you again, Dr. Nathan Chomilo. Thank you for letting me butcher your name the whole time. And
no worries.
I'll do better.
Thank you, Angela.
Have a good day.
You too.
Thanks for listening to the Little Moments Count radio podcast in partnership with community radio stations throughout Minnesota. You can find the Little Moments Count radio podcast wherever you get your podcasts and at littlemomentscount.org/podcast.